On behalf of GDP, I welcome Dr. Afaq Ahmed Khan, the Master in Hospital Administration, and much more. As I said, tremendous amount of knowledge. Dr. Afaq Ahmed is a well-qualified and practicing administrator. His magnificent profile could be briefly introduced as Dr. Afaq Ahmed did his Bachelor in Dental Surgery from MS Ramaiah Dental College, Bangalore. His postgraduate diploma in entrepreneurship management as well as operation management from Madurai Kamraj University, Madurai. He did his postgraduate diploma in hospital administration from Medversity Apollo Hospitals, Hyderabad. Dr. Afaq Ahmed has completed his MBA from Academy of Hospital Administration, Delhi. LSSBB, that is Lean Six Sigma Black Belt certification from International Management Consultancy, Abu Dhabi, UAE, ISIL Global. Dr. Afaq Ahmed is founder and director of Health Services Private Limited. He has been the project head of Welfare Hospital Administration and Operations from 2008 to 2010. For the period of 2017 to 18, he has served as pre-accreditation for the NABH as technocrat and head of the operations for Dr. Ambedkar Medical College and Teaching Hospital. He's been actively involved with many organizations as well, like he's a life member of Indian Dental Association, founder chairman of ProNet Welfare Foundation, executive founder member of Association of Diagnostic Centers, Bangalore, executive board member of St. Germain Academy, Bangalore, National Council member, Indian Muslims for Policy Reforms, member of Rotary International District 3190. He's been the ex-General Secretary of International Human Rights Commission, Karnataka. Also served as the Charter President of Rotaract Bangalore Brigades. Time does not permit to highlight all his achievements as we wait to listen for him. Over to Dr. Afaq Ahmed Khan. All yours, sir.
Am I audible?
Yes, sir.
Yeah. Assalamu alaikum to all the viewers. And first of all, I am very humbled by the kind of introduction Afzal has put forth using words like genius and other things. I'm really humbled. Thank you so much. I don't think I have taken even baby steps in gaining knowledge. I have a long, long way to go. Yes, one thing which I recently completed was certified professional healthcare quality from states, CPHQ. Quality has been a passion for me. As I'm beginning my presentation, primarily one particular thing which Afzal said, especially about change, really caught my mind. Because change is the single most, in my personal opinion, it is definitely debatable, but it is the single most, and the most neglected aspect of life which one has to follow. Change in everything. I mean, you can't have idli vada continuously for 5 days. No, you can't. You'll break away. As simple as that. So change, adapting to change, and going forward with change is the key. And quality management does that only. So I will start my presentation. I'll try to share the screen, but I would prefer to do talk, and you're welcome to ask me anything. Whatever is within my knowledge limits, I would love to share it to you. Give me a moment, please.
It's quite true, sir. Actually, as you said, learning is a lifetime process. By the time you share your screen, I'll just add a few things, because once we start practicing, then we realize that our clinics has to be registered under government, and there are so many norms like pollution controls and other things. So we'll be enthusiastic to know all such things from you.
Right. Is the screen being shared?
Not yet, sir.
It's being displayed as shared here.
Recording in progress.
Yeah.
I guess now it is being shared, right?
Yeah, it's there, sir.
Yeah. So, as we discussed, today's topic is quality management in healthcare and dental practice. When we say quality management, we are basically referring to doing the right thing at the right time in a right manner to the right people. Okay, this is my version of what quality management is. Now, going by this is a brief up about most of the webinars that we do. This is a brief up about my organization. Since we are doing quality assessment and quality accreditations to many organizations, I thought I will share this slide also. So since we have little less time on our hand, I will get into the detail of what exactly quality management is. Okay, quality management, as I told you, is defined by the World Health Organization in terms of STEEP. When we say STEEP, we are discussing different aspects: safe, accessible, timely, then efficient, effective, equitable, and people-centered. Okay, the World Health Organization, the JCI, that is Joint Commission International, then the NABH, the NABL, then the ASHQA and the ISHQA, all these organizations are directed towards quality management in hospitals and healthcare systems.
Of just late, one second, sir. Sorry to interrupt. It will be better if it could be a slideshow. The complete PPT has been displayed.
So since this is a PDF, you need to go to the properties and then click on the single view.
Properties at
yeah. See, this is the PDF. It's not a PPT. Yeah, please.
Yeah. Now, coming back to the presentation, as I told you, quality management, total quality management is divided into various aspects: quality assurance, quality control, continuous quality management, that is called as CQI, and thereon it goes on and on and on. It's a very complex, like how Afzal said, it is a very complex system and a very, very vast subject. I mean, you can have the probably double, triple post graduations only in quality management of hospital and healthcare system today. It is diversified so much. Now, in simple terms, let us try to understand what exactly is quality. I'm sure most of us sitting here are knowledgeable and have knowledge of what quality exactly is. But to give an example, a little more precise example, I say that quality is the single most factor that drives people to wealth gain, reputational gain, and revenue multiplication. When I say this, am I neglecting the patient care? No, absolutely not. Because if you have patient care at the core system, then this acts like a canopy. So in my previous stints, there are other couple of stints where I did. I was also the technical advisor for a brief period of time for pilot projects for biomedical waste management in Karnataka. At that point of time, I tried to bring about a quality management system in the very aspect of entire biomedical waste management with one Dr. Raju, who was a head of biomedical waste management. And you would not believe it, there was a superb outcome which made most of the hospitals mandatory to practice biomedical waste management. This is the time when we had Karnataka State Pollution Control Board trying its norms, and I was also part of the panel where its suggestions in 2006 when NABH wanted specifically for dental. So I did put forth my suggestion. I did not formulate them though, but I did definitely put forth my suggestions. So coming back to quality, now I told you the World Health Organization, the JCI and the ASHQA, all these organizations are defining quality in their own aspects, in their own terms. But I would put it in a very, very simple manner. Quality is doing the right things for the right people at the right time and doing them right first time and every time. I hope you are understanding what I'm saying. I hope I'm audible too.
Yes, sir.
Yes, sir, you're audible.
Yeah. Now, moving forward to dental quality management. Now, you would not definitely find any particular specification of dental quality management or definitions of this, because it is overall, as I told you, a canopy. Healthcare itself is a canopy. So when we are talking about the canopy, then dental, medical, physiotherapy, every aspect of healthcare comes into the picture. It's like an umbrella term. Now, however, just for our dental friends and dental brothers here, I have defined it and assessed it according to setting with factors such as standards, laws, regulations, accreditation, and consumerism impacting the measurement and analysis in tremendous ways. This is how quality can really impact an organization. Be it a single service provider or a dental unit with 11 chairs or a dental unit with 3 chairs, this is the impact what quality can do. So dental care today is worlds away from other point in history, because I think we'll all agree that it has been a very, very, very fast-paced growth. Increasingly, increasing factors of technology, then optimal patient care, and various aspects. There is a complete 2 decades back when I graduated out, what it was, and today what it is. There is a huge difference. I think all of you will agree with it. Do you want the interaction to be, do you want the presentation to be interactive, or do you want me to just go on talking? Because I don't want my brothers and friends to sleep off. Okay, now coming to the STEEP. STEEP, again, this is a definition from the World Health Organization, which states that quality healthcare services should be safe, meaning delivering healthcare that minimizes the risks and harm to the service users, including avoiding preventable injuries and reducing medical errors. This is the first highlight the World Health Organization gives. What? The safety of the patient. Unless and until there is safety of the patient, it cannot be considered as a quality service. Second, it should be timely. There shouldn't be delay in times, and there shouldn't be short durational treatments also. So reducing delays in providing, reviewing healthcare, receiving healthcare, or providing any particular surgeries, protocols of management of acute to chronic cases, everything should be done in a particular time frame. Third, it should be effective. You're doing a treatment, you're doing a procedure, of course it has to be effective, but effective based on whom? Effective based on my mindset or somebody else's mindset. So that's where the accreditation comes in. It has to be effective based on the scientific knowledge and evidence-based guidelines. Then it has to be efficient. delivering healthcare in a manner that maximizes resource use and avoids waste. It has to be efficient. Equitable, delivering healthcare that does not differ in quality according to personal characteristics such as gender, race, ethnicity, geographical location, or socioeconomic status. People-centered, providing care that takes into account the preferences and aspirations of individual service users and the culture of their community. Now, this is as per the World Health Organization. I would not want to go detail into the aims and objectives for quality in health and dental care, simply because it is a very vast objective line. So by the time I finish it, it will take me another 1 hour only to finish the aims and objectives. In simple terms, let us understand it is to meet and surpass or supersede the need of customer satisfaction. That's all quality is. The aims and objective of quality management is to meet the needs and supersede the customer satisfaction without compromising on ethical practices. This is what the aims and objectives is. Just for your knowledge, I have shared you what all the aims and objectives are mentioned in various books and authors across the line of this particular profession, especially so with accreditation bodies. Do you want me to go in depth of each one of them?
No, sir. Better it will be a gist can be just told and we can rush.
Yeah.
Because there are more important aspects, I feel. Which
I have told it in one simple sentence. It is to meet the customer needs and supersede their satisfaction. That is what it means. Wherever it is, whether it is a hospital admission or a dental treatment, anything. So Dental Quality Alliance was first launched in 2008 to 2010, and this was an American body which established American norms for Quality Alliance, and they have close to around 62,000 practicing dentists registered from the beginning till now. Now, their objective again was to identify and develop evidence-based oral healthcare performance measures and measurement resources. This was followed by the IDA along with the lines of NABH. The IDA came up with the idea that we should go with accreditation for dental institutes also, and they moved out and prepared a charter wherein the patient, the students, the institutes, the society in general could be benefited as stakeholders. So they have enlisted in their in their program what benefits are for the institutions for the accreditation and what are the benefits for the dental professionals. Now, dental professionals can be assured with continuous dental education, which can balance high academic quality and professional relevance, and that the needs of the corporate world are well integrated into programs, activities, and processes. Now, I'll take a pause here, and I would like to ask my fellow colleagues here, is there anything that you want to talk about before I proceed further? Of course, we'll have a brief discussion at the end of the program. The reason I'm asking is because, it is so volatile that it should not escape out of people.
No, so actually, this was the question. Like I would have interacted or interrupted here. The benefits of accreditation in dentistry, because hospitals usually go for NABH and other accreditations. So actually, I had a question of such kind, but I feel that you're clearing it.
Yes. So these are the benefits. What the Indian Dental Association states that after getting accreditation by the IDA, these are the benefits. But furthermore, now all the dental units are open for NABH accreditation, no matter how small they are. As of now, they have enlisted minimum 11 chairs for accreditation, NABH. But QCI is Quality Control of India. I will come to all that. See, I don't want to, move out of one particular topic and then later on, regret that I should have, passed on this knowledge. Even if you have, I would have revived it for you. So I will come to that part of it. Now, as per the IDA, These are the benefits that are available to the dental practitioners. Now, IDA and NABH both identify a single dental practitioner as DHSP, that is Dental Health Service Provider. Dental Health Service Provider. Now, can anyone tell me, or Afzal probably can share a word with me, why quality is important?
According to, like from my side, I'll definitely, sir. If anyone else wants to share something, some views, can chat, or I could unmute.
We will have an interaction at the end of the event. But I just want to know why do you people feel that quality is important? We all know that quality is important. I'd like to know, why do you feel it is important?
In a way, I think quality determines the individual success, maybe the loyalty, and then the return, and then also the recommendation of the patients.
Excellent. Anything else?
And it helps in terms of growth as well.
True. True. Anything else?
It improves your reputation.
Fair enough. Anything else? The list can go on, because quality is so important, isn't it?
And nowadays, actually, quality is more important, because we have many things like the upcoming quacks and many other issues which usually IDA deals with and other things. So it is only quality which will prove us and will have a stand. We know that 100% cannot be given, but still we could be very close to perfection, and we can defend our treatment if quality wise, if we have delivered. If we have a poor quality, then even we don't stand. And maybe as far as the legal aspects are concerned, even their quality matters a lot, as per my knowledge.
True, absolutely. Now, most of the answers that were shared are 100% true. Also, quality is the single most driving factor to reach a benchmark. This is very, very, very important. See, according to me, the quality could be, this particular level. According to Afzal, it could be at this particular level. According to Nair, it could be at this particular level. So who defines which quality is the best for the patient? So we focus on quality primarily to reach a benchmark which is universally acceptable by all. That's where the accreditation comes in. Now, when that happens, you have various benefits, various good factors. There is reduction in preventive errors that can happen. I will come to that. These are the 8 dimensions of quality as defined by the Quality Council of India and the ISQA regulations, that is the Asian and the American regulations. There are different dimensions. Now, each dimension can be spoken at length, at large, with various examples. I have written a small book on quality assurance and quality control in healthcare. So there are 2 books that I have authored. One was in administration and another was in quality. So the quality control book is available with me, and I've not gone publicly to print it yet. But in this particular book, I have mentioned all this in a different length, and each aspect, how it affects the patient, how it affects the consumer, how it affects the payer, whether he is patient or not, and how it affects the institution or the organization. So just for our information, there are 8 dimensions of quality. This were given way back in 1988 by a gentleman called Garvin. Most of the quality-oriented work has come from a couple of organizations such as Toyota, most of the Japanese organizations, okay, wherein they have brought about 6 Sigma, Kaizen, PDSA circle. Afzal is having a smile on his face. Probably he's recollecting his graduation days. Performance, futures, reliability, conformance, perceived, aesthetics, serviceability, durability. These are the 8 dimensions in which the quality works. To further explain to you, I can say that this is an umbrella during which you have all the, the strings of attached to the umbrella. The what do you call those wires attached to the umbrella are in this particular format, and the quality acts like an umbrella with these elements in between. Now, I just want to take 2 minutes of your time and briefly explain to you what is quality control and what is quality assurance. So it's like revision for Afzal, I think. But for the rest of you, quality control and quality assurance are two different terminologies. Basically, quality control is an evaluation process. I am doing quality control in my clinic means I am doing an evaluating project. I am doing quality assurance. I have already evaluated it. Now I am monitoring it. So you see, both of them cannot be away from each other. They have to work in sync. Dr. Nair has gone in and evaluated the complete process of quality in his dental unit. And Dr. Salman is ensuring that he is monitoring what he has evaluated. So the quality control and quality assurance together form quality management. Total quality management happens, I hope I'm explaining clearly, total quality management happens when these two elements mix with continuous quality improvement cycle. You have quality control running, you have quality assurance monitoring, and continuously there is a quality improvement process happening. When these three things combine together, it is called as the TQM, total quality management. Now, to talk these terms and this terminology sound very big, but when you come to the basics of it, we are actually doing it in our practices everywhere on a continuous note. Don't we look for quality in things? Don't we look for
definitely we look
quality when we're buying a cell phone?
Yeah.
So don't we look for quality when we're eating something?
Yeah, even minute
We
smallest
do, right?
Yeah, we do look for quality.
We do or not?
Yeah. Am I audible, sir? Yeah.
Am I audible?
Yeah, you are audible, sir. Am I audible? I don't.
I think both of you are audible.
Yeah. We do definitely look for quality, even if you buy a smallest thing. Definitely, and nowadays it is a quality era itself. We always go for brands because of quality. I think the video has stuck. Yeah.
What happened?
There's a small issue, sir. It's fine, sir. Now I think it's audible to all. There was a small stuck in the. I think there was a pause. Yeah, definitely we look for quality, and nowadays it is.
I'll just share the screen now. Give me a second.
Yes, sir. Yes. Yes, sir. Definitely. Yeah, sir was speaking about quality. As I said, we definitely go for brands nowadays. It's just because of quality. We can buy something from the roadside also. Maybe a pin or a pen or shoes or anything. But we look for quality for betterment and for the long lasting results. I feel as in dental profession, if suppose I give some restoration, the patient definitely desires or patient intends to have a restoration which has got a long life. Maybe we prefer a crown if it is too much damaged because of the life, because patient may come back with if a poorly restored teeth, the quality, if the quality is hampered, then definitely the patient may come back the next day itself. So everywhere, even in the smallest thing, the quality matters a lot.
True. I was asking this question to all of you: why focus on quality? Is the presentation Viewable by all?
Yeah, it's not visualized, sir. The screen is not shared, I think.
No, I shared the screen.
Yeah, screen is there, but the PDF is not visible.
Goodness Lord. Your screen sharing, it is showing. Are you sure it is not visible?
The screen is visible. I think the PDF is not open.
Yeah, it's not open. The screen displays all the files and other things. The PDF is not open. Yeah, I think it's fine for everybody now.
Is it viewable?
Yeah. Yes, sir. Yes, sir.
Okay.
Second continues.
Okay. So I was asking this question, why do we really want to focus so much on quality? You know, it could be just a standard practice and let me have my own way of practice. You know, I know what is best for my patients. What my consumer wants is ideal. I have to be very adaptive. You know, psychologically, I need to understand, read the minds of a particular community, staying in a particular region. I need to cater services to that crowd. So I can't really focus on quality. Now, here are the alarming facts why we need to focus on quality. One aspect which I really didn't mention when I heard all the answers was the preventive errors. It is estimated that globally, of the 421 million patients hospitalized annually, 42.7 million patients suffer from adverse events, which could have been prevented. Now, 2013 study, honestly, we don't have much study on this in our country, but there is one Professor Jha who had conducted various studies, and I'll share his data also. 2013, a study stated that unsafe care is third in the rank of cases of death globally after heart and cancer, after cardiac and cancer. The unsafe care which is given to the patients, you know, is ranking third. So you can imagine all this is happening because there is no quality benchmark followed. Considering this type of magnitude of a problem, it becomes a major public health concern. Now, between 44,000 and 98,000 Americans, anywhere between this die each year because of preventable errors, not following quality benchmarks, not following the laws and regulations laid by accrediting bodies or quality councils, which they could have followed. I think all of you will agree on this. Now, I was managing a chain of polyclinics in UAE, and I just want to quote this very unfortunate incident. And the team of nurses working there were Indians, and I did a small project report for them on Greenfield project. So when I went there, the lady was using the same injectable which she had used last night to the patient next day morning. Believe me, and this happened in UAE. Of course,
I do agree with this thing, sir, and if I don't interrupt, definitely recently the treatment of even COVID, a lot of patients, lot of deaths, I feel, okay, they were all attributed towards the poor quality.
110%, there is no doubt about it. 110%, there is no doubt about it. I know I have been shouting from rooftops, Afzal, and all of you, you need to be informed wherever possible. हमारे जहाँ पे इदारे हैं, even those places have been shouting from rooftops that we need to bring in quality practices. We need to have a universal costing. We need to have a universal policies adapted, and we need to register people and ensure that we monitor them so that this is followed. This was a sincere attempt which I did in Association of Diagnostic Centers because I wanted to break the referral system, primarily because it is not allowed in Islam. It was a very humble attempt, may Allah accepted. So I still don't, my center and my businesses don't entertain this at all. Just to tell you that, you know, when you're doing that, the quality is totally compromised. I have doctors and quacks who hold the ETTS sample in their hand and give the report for CBC, complete blood count, believe it or not. I have documented it also. I've just not gone public about it, but I've documented it also. The sample looks very lipemic, maybe high cholesterol, assumption. So morning the patient gives a sample in the clinic, and the evening the report is come without processing the report at all. All this is happening because there is no quality standard control methods at all. And if there are, no one is following them. And if no one is following them, there is no body which is taking them to task. This is a cycle. Now, the dental care market in India has been highly unorganized. It is estimated that there are more than 80% standalone clinics. What is even more shocking is that owing to the gaps between the dental health services and awareness towards oral hygiene, there is a mere 2% penetration of dental care. To all the people who are practicing dentistry in clinics as well as hospitals, this is a report from a verified and a very good authentic source published in Mint. Can you imagine? We have a 2% penetration, just 2% penetration. Now again, believe it or not, awareness is lacking. Why is awareness lacking? Because people are not having trust due to uneven, substandard practices in dentistry. Now, I think all of you know about this. Now, moreover, as per the latest statistic, there is a concentration of only 10% of dentists, where approximately 70% of Indian population resides in rural areas. This is another concern where we do not have business outcomes, and where another concern because we do not have quality treatment being given to the rural sector. Now, what happens if we have a universal quality policy, deployed by each individual unit, starting from one clinic, let's say Afzal's clinic, or let's say Salman's clinic, or let's say, I can see only 4 of you, so I'm recurrently taking your name. Kindly don't mind. Now, what happens if they start one, and in 1 year, there are around 1,000 clinics registered in a particular body following quality norms fixed as per the NABH? What happens then? The next and will blindly come in. Another important thing which when we discussed why focus on quality, we really didn't talk about is the insurance. The next era is going to be the insurance era. Dental insurance is going to become rampant, just like how healthcare insurance is. I think some of our friends are from Middle East also. I was told by Dr. Gausia that there are some Middle East individuals also here. So they know that, everything happens with insurance there. The same thing is going to happen in our country also. And when that happens, no insurance organization is going to give in to any of our units unless and until we are not accredited. And to be accredited, we need TQM, that is Total Quality Management. I have spent quite a lot of time in statistics, and let me come to I'll zero in now on the NABH guidelines which are available for dental practice, which identifies dental practitioner as dental health service provider, DHSP. Now, they refer it because there are a lot of individuals, as I told you, there are a lot of standalone clinics, and due to that factor, they refer them as DHPS, individual dental health service provider. It could be a hospital also, but they are currently giving accreditations to minimum 8 to 11. We have requested in the Quality Council to reduce that figures and convert it into 2 to 4, because we want be in the sense a team of quality analysts across the country want NABH to consider that every organization comes under a preview of accreditation. The more faster, the more numbers come in, the more quality treatment is given to the rest of the world, the society in pass. Now, NABH has got 10 chapters and lot of guidelines. Each chapter is covered with a particular guideline. Now, these 10 chapters, supposing my institute or my organization needs to get an NABH certificate, the process is very simple. They have these chapters. We need to follow these chapters, meet their particular requirements. Once we meet their particular requirements, there will be an NABH assessor who will come to our center, our hospital, our clinic. He will evaluate all the things and give you pre-accreditation certification. Once you have the pre-accreditation certification, the next 18 months, they will do quality assurance, the monitoring process. Once the monitoring process happens, then they give you the real-time NABH certificate. Okay, this earlier I showed one particular slide wherein, you know, this is the first NABH accredited dental unit in the country. Which way? Yeah, this one. I don't know if it is the same doctor, and I can't zoom in. But this is, as per the records, the first dental unit which was accredited. Now, coming back to the chapters, let us understand the first chapter, access and assessment. Now, most of the dental units, when you walk in, do not have display of all the services provided by the DHS. Do you agree?
Yeah.
You know,
Usually,
you have either got
don't
a
have
smile smile being shown, or you have a particular, you know, orthodontic appliance being shown, or, you know, you don't have all the, as per the NABH, you need to display all the services in a uniform manner without having any change of cost mentioned on this on the display and charged differently to the patient. So that is the second point, displaying of all costing information. Yani, what I'm basically trying to tell is that NABH will warrant you to ensure that all the cost. One patient came, I'm seeing that he's wearing a gold bracelet, I'm going to charge him 2,000 rupees. I'm just joking. This is not what is NABH expectation. You know, NABH here is an accreditation body, right? So basically, when I'm talking about NABH, I'm talking about quality. It is not the ultimate body. We have Quality Council of India, which I feel is much, much more stronger. And we have various other international bodies. I'll discuss that also briefly with you. Now, access to the patient should be very wide, clear, loud, and transparent. This is the zest of this particular chapter. Next, assessment. You need to assess the patient's chief complaint. Of course, we all have to assess the chief complaint, but along with medical and dental history with records. Initial assessment should be followed with provisional diagnosis, treatment plan, costing, detailed explanation to the patient and attenders. Now, here is a catch. This we are doing routinely. So why mention it? We mention it here because whatever we do should be recorded. Not a video recording. You need to have a software compliant process and a hard copy process in place to show that the access and the assessment for the patient was absolutely as per the benchmark standard. You need to have a unique ID. You need to have a callback access. If risk factors are there, you need to mention it to them. Let me tell my friends here, we still have people joining in. Access and assessments, what I mentioned here is just a zest. When you go to NABH, the chapter is huge. You know, they want you to go more concentrated in each particular aspect, and they give you a detailed explanation. This is how you're supposed to do. This is how you're supposed to do. You need to appoint one person who is going to be accountable for this particular work, and he should, you know, have a performance indicator in place where he has to, you know, mention everything and put a sign in. I am giving you just the zest because I know there are time constraints and I know this is just the beginning. So you could say that this is like, you know, a small taste bite that we are giving you. I'm repeatedly telling you. I hope my brother Afzal can, you know, can understand when I say that this is a very, very vast subject. Right?
Yes, sir, definitely.
Now, second, yeah, go ahead. Tell me, you're telling something.
Yeah, definitely, sir. It has got a lot of roots. Maybe in one session we can't complete the entire thing.
True.
But it has been very well planned.
Yeah. Second is the care of patients. Now they have a SOP. SOP is nothing but standard operating procedures. You need to have a structured SOP, inclined care of patients with documented policies, procedures, should act as a guide to the journey of the patient. Various examples can start from diabetics to CPR. No, we all agree that there are dental emergencies, there are medical emergencies also. A medical emergency can happen even in a flight. It can happen in a dental chair also. More prominently, the possibility of it happening in a dental chair is more prominently present. I hope all of you will agree with me. A patient can go into cardiac arrest, can go into hypovolemic shock, it can develop anaphylaxis, type 1 reaction, whatnot. Anything can happen. So there has to be a documented policy kept in place and emergency medication kept in place so that that documented policy and emergency medication is followed as per the benchmark standards. Do we all have this in our clinics? Not the ones who are attending. I'm generally talking about our society. Do we have this in our clinics?
Not SOPs are not exactly followed. Maybe a very few.
No, do we have adrenaline? Do we have something to handle anaphylaxis?
Since the
anaphylaxis type 1 reaction?
Yeah, KPME norms do require presence of dexamethasone, adrenaline, and emergency drugs.
Yeah,
for registration,
the norms definitely need us to have all those. But are we actually having them?
Yeah,
I'm
in
not talking
registered
about
clinic, wherever
individuals. I'm
inspections.
talking about in general.
Yeah.
I'm talking about in general. Definitely not. I can assure you 95% of the units operate without having a backup plan for emergencies. 95%. So evidence-based clinical practice should be followed. Specific post-treatment protocols, guidance should be practiced along with the set guidelines for healthcare. Support and or working team should be aware of the same. Now, in so many instances, it so happens that I'm the chief dental practitioner, and there is a team which is joining and leaving, or support team which is working besides us. They are not aware of all this. So the NABH warrants all the members of the organization or the clinic to be completely aware of all the procedures and protocol. They have been stressing on this right from the beginning. Now, patients has their own rights in education. The third chapter speaks about that in detail. And this is also very important for medical legal aspects, MLC cases, educating the patient, displaying of the patient rights, respect for personal dignity and confidentiality during the course of treatment, acknowledging his or her refusal to be treated, then access to the records. All this has to be univocally followed by all units who want to get accredited. Now I'm talking about accreditation. The topic is about quality management. Believe me, both the same. Quality management and accreditation are hand in hand. You get accredited only if you have quality. That is the reason why I'm talking about accreditation. In simple terms, patients should be educated about estimated cost and outcomes, and support team again should be aware of all this. What are the patient rights? The support team should be aware of it. Just the dental health practitioner knowing about it is not sufficient. And above all this, the DHSP should be committed to the same on a recurring basis. The patient right should be displayed. The patient should be educated. This is the third chapter. Can I move on?
Yes, sir, sure.
Yeah. Now, the fourth chapter is the dental equipment, materials, medication, and instrument management. Again, it's a very lengthy chapter. I'm concising it and telling you. The emergency medicines should be available at all times during treatments. Then the ARB license. ARB license is nothing but the Atomic Power Research license for the radiology aspects, and they give you a badge. A small pause here. Are we all following this?
Like participants, please do.
Yes,
interact.
we are following, but we don't have those badges because lately I came to know that we as dental professionals, we don't require badges because the exposure to the dental exposure is quite minimal. That is what I heard, or probably I was misguided or not. You could just throw some light on this, please.
Yeah, you're right. The dental exposure is very limited. Okay, 100 mm machine also. Sometimes we have a 80 mm machine and 60 mm machine. These machines also do not require. But having a badge with a radiologist friend of yours is always helpful. Now, see, institutes like hospitals and healthcare are so strict and vigilant about this these days that every 3 months we send the badge back to them. They check the level of radiation and then send it back to us. Only then we can start doing the X-rays. For the 2 days, we cannot do X-rays. Okay, so the dental X-rays, ARV license, when ARV license is coming into picture, it simply means that, the monitoring of radiation is happening. So we need to have document policies that should comply with the law. Storage usage of medications, materials as per the manufacturer's guidelines, and non-usage of expiry items, regular monitoring of it, documentation, and which from the beginning, from the A to the Z of the entire process is always working, always, shouting about documentation, whether either it is in soft format or it is in hard format, they want documentation, and that is how the process happens. So when I say that, ARV license, when was the badge reviewed? When was the emergency medicine purchased? What are the expiry dates? Who is monitoring this emergency medicine? And what are the, storage practices? Are the storage of materials happening? How many of them are rusted? Are they using rusted materials? So everything needs to be documented. That enhances your quality. Then comes the infection control systems. Now, infection control system, as all of you know, as we have studied it basically in our graduation days, and we have followed up, and unfortunately not following, okay, most of us. So we need again to have a documented infection control mechanism with the team and or
sir, can I interrupt?
Person. Yes.
Yeah, just there are a couple of questions coming
Yes,
because relevant to the patient education.
Please.
And the first one is about the cost of getting private practice accredited.
Pardon me?
A cost for getting a NABH accreditation.
I think it is 4,000 rupees. Okay, when you ask for, see, the process is different. I will come to that at the end of the program. Okay,
sir. And one more question is related to the patient's right. So when we speak about patients' rights of education, are they standard or relative to the individual practice?
No, they are standard. They're absolutely standard, and they have a set of rights which are already mentioned in the QCI and the NABH, which you need to have a display. There are about, I think, vaguely I remember, I think around 24 points or something are mentioned in the booklet, which you need to mention it at the display. This is your right. Be aware of it. This is your right. You can refuse treatment. You can get, compare the cost of the treatment. All this are the basic things that are mentioned in the rights. It's nothing targeting the practitioner or the hospital or the healthcare system, but again equipping the patient with more control for quality.
Yes.
Yeah, so the infection control mechanism and the infection control system in individual clinics and hospitals. Usually when I give a presentation like this, I'm always talking about hospitals. So today I'm, concising and talking only about individual units. And I hope I'm trying to do justice on that. You need to follow, because see, when we talk about hospitals, we are talking about air mechanism. We are talking about complete internal infection control systems. We have 18 levels of infection control systems. It's vast. Again, OT completely different, likewise. So when you're talking about an individual unit, adherence to standard protocols, vaccination of the existing staff. I think most of the staff should be vaccinated for hepatitis B, and now COVID also. Okay, and biomedical waste management. I have a friend of mine. She was doing extremely well during the COVID times, and a lot of patients used to come to her. She's a dentist, and a lot of patients used to come to her. On a light note, I asked her, oh, not bad, yeah, people are ready to come and open their mouth in front of you during these times. She said, the best part about my unit always has been that we are very, very particular and very strict to, clean, hygienic measures. We maintain extremely hygienic measures, and this has motivated patients to have trust and come to us. So continuous and aggressive encouraging the infection control system. I mean, patients are not fools these days. When they walk in, they realize there is a cobweb formation in one corner of the clinic, you know, and there's a bottle which has got a expiry date, you know, they realize. I hope you're understanding what I'm saying. They, you know, you're asking them to leave slippers outside and come, and whereas you are wearing inside and walking around, kya baat kar raha hai, infection control ka, theek hai, I have pain, I'll come and get it done and go. But eventually, that will not motivate them to come back. So when we bring about quality management in infection control, in hygiene, then it has a huge impact. I am moving on. Now, if there are other MBA graduates here, they would understand what I'm saying. Even MHA is an excellent thing to do. We study something called as a continuous quality improvement, that is the PDA cycle, which we call it: plan, do, action, and check. It is a continuous process. PSDA we call it. Okay, so if you go and Google it, you will find various methods and technologies. The quality control and quality assurance methodology is to be implemented by the way guidelines are set, mission, vision, quality policy of the unit or the hospital or the healthcare system, benchmark, risk assessments, and the management protocols should all be incorporated into the structure. The principal DHSP, that is the practicing dentist and or the designated person, should be well trained to achieve the desired outcomes, understanding the dimensions of quality, methodology to improve quality and attain the same as desired by the accreditation bodies. So the sixth chapter in NABH for the dental practitioners is to work on continuous quality improvement. Okay, now this is what we have been actually talking about from the beginning. They just have put it in a chapter and they've enlisted a lot of points. Facility management and safety. This is the seventh chapter in NABH. The hospital or the clinic safety manual should be made available at all times, should contain information, policy statement, guides, and safety prevention. For instance, just for an instance, I'm giving you. See, when I read the data here, then the flow of talk, what I want to do is you know, settled down. So let me talk what I want to. I've just seen the topic. You have a mechanism to ensure that there is fire safety within the clinic. You have a mechanism to ensure that if the clinic is on the first floor, then if God forbid the patient is suddenly developed epilepsy, how are you going to take him down? So special safety measures for patients have to be planned and documented. That's all it means. Of course, chemical hazards, you know, used in the laboratory, physical hazards, ergonomic hazards. You have a chair which is not compatible for sitting. Even that is evaluated in this particular facility management and safety for patients. Facility management, in addition, will also include things such as, you know, your safety gear like goggles and you know, protective clothing, not only for the practitioner but for the entire team. Supposing a patient is coming and there is a patient attendant along with that, it is applicable for that person also. Can I move on? Am I going at a very fast speed?
No, sir, it's quite explanatory, and the
I
points
really
have
hope,
been
because
highlighted.
honestly speaking, when I was told it is 45 minutes, I was a little, you know, kind of worried, because at the end of the day, you know, there should be a win-win situation. I should feel that I have done justice to what I tried, and you know, my colleagues out there should feel that yes, we gained some knowledge. This is what I'm trying to do. That's all. So the management responsibility is the 8th chapter, and here medical code of ethics are emphasized. The practitioners should follow, because it is talking about the management. When the management is not you know, really caring much about all these things, then nothing happens. So they have brought in the responsibility of the management. We have something called organogram. Organogram is a process where, you know, from the top management till the lowest management, everything is planned, clearly documented in the hierarchy. Hierarchy is nothing but, you know, this person is responsible for that, that person is responsible for administration of the unit or the hospital. The organogram and the hierarchy should be properly planned. If the organization is following or the unit is following affiliations and accreditations in an honest and just manner, this is for the management. medical code of ethics should be followed. Management should ensure the safety, risk of all personnel, those receiving services, supporting services, and the one's own self in an equivocal manner. So basically, the management, in simple terms, should be responsible. I would say that हम लोग सब मिलके अगर अल्लाह को राजी करने निकलेंगे तो we start finding lutf in everything that we do. Now I want my patient. I have patients coming in. I want to give quality report to the patient. I'm sorry, I'm not supposed to be talking this, but with the flow of thoughts, this is coming. Imagine for a moment I'm getting this feeler that I want to make sure that Allah is Razi because I'm making sure that the creatinine levels are rechecked twice because they were on borderline. Then automatically the quality comes in. I hope you agree with me. So when we have this conscious factor as a management that we want to give quality to our patient for the sake of their health, that is what this chapter means. Then we have human resource management. That is the 9th chapter. The organization has a document system of human resource process for staff recruitment. We don't blindly take staff. We have a background verification of the staff. We have a CVC. Briefly, because the HR is again a very vast field. But when you have Am I again gone?
No, you're audible, sir.
And the screen is again gone.
Screen is not visualized.
Is the problem from my end?
I think there's a technical glitch from your end. The share screen, I think it's just dropped out. You had dropped out for a moment and then you back again. Yes, we are back.
Yeah, it's there.
Yeah. Generally, I don't have this problem, but I don't know why I'm facing this today. Anyways, no issues. The organization or the unit should promote the well-being of the staff employed, the people working, take care of the documentation process and retain the documents for future use. The 10th and the final chapter, I feel that in today's world, this is one of the key factors for business growths. When we're talking about business growth, we're talking about everything. Is the information management system. We call it IMS. Information management system is basically nothing but complete information, data building, data retaining, data usage, and data accessibility. That is information management system. Now, every hospital needs to maintain a complete and accurate medical record of every patient. Every medical record has to have a unique identifying number. Now, the contents of the medical record should be identified and documented. We have something called the ICT rating. We have something called international disease chapters. I think you're aware of this, Afzal. No? So we study this and the same has to be incorporated. Now, in dental also, I was told that similar softwares are coming wherein you can maintain all the information for the patients in a dedicated software. You have one which is a billing software. Now you have certain prescription softwares also available at your disposal. Second, care providers have to have access to current and past medical history. Then the confidentiality and the security and integrity of medical records need to be maintained. We have a particular protocol that the medical records need to be maintained for this much of a period. And you can destroy it after this much of period. For income tax purpose, you need to maintain it. Let me say it here before I forget it in way ahead. You need to maintain the medical records for minimum of 3 years, okay, as per the law. And for income tax purpose, you need to maintain it for 7 years. As per that individual who is mentally retarded, you need to maintain the records for that time until the unit is operational, until the hospital is working. Okay. Now, documented procedures need to exist for retention time of medical records. Documented procedures should be in place for retaining the medical records. Then the destruction of the medical records should also happen in a laid down manner, right? Now, quality as a canopy and a universal policy. I'm sorry, health tree has come in because with a specific. It basically means to say that these are the governing bodies which are responsible for accreditations. The ISO certification, NABL, that is for laboratories, NABH, that is for healthcare units, hospitals, primary, secondary, tertiary care hospitals. Then you have International Society for Quality Upgradation and Accreditation Standards. So this is my recommendation. I recommend that the quality is one single most tool when implemented at any and every and at all levels of hospital or healthcare system will change the very dynamics of the delivery to the end customer. However, a lot needs to be done in pursuit for achieving this. Basic level warrants regulations to set according to clinic, polyclinic, alternate medical practices, and that these regulations should become mandatory protocol for functioning, if not meeting the regulation. The very functioning needs to be ceased in case it is not being followed. At all levels of primary, secondary, and tertiary care hospitals and teaching colleges, there needs to be a canopy of quality over the entire organization. Accreditations are the best way to take it forward. The different requirements of quality, such as the ones which I mentioned, all integrated would render the best healthcare systems in the world. Now, these are the benefits of having quality in your individual practice. However small and however big we have our own practices, even quality is incorporated, these are the benefits that you're going to have. One, you're going to strengthen the competitive position. Second, your adaptability to changing or emerging market is met. You have higher productivity. You have increased customer loyalty and retention. You have improved and innovative processes in place. It is mandatory to quality management and accreditation is mandatory to meet many government schemes across the world. There is obviously high profitability, reduced cost and better cost management, enhanced market image, increased job security. I'm working in a place where there is quality, then automatically my job security will be more because I know this place has got quality. Today if I'm going to walk into a restaurant and eat good food, I'm going to go back there because the food is good. And why the entire quality process was good, not just the food. The tables were good, the waiters were handling things very nicely, there was distance being maintained, the pleasantness of the individual. So all that is going to fall eventually in the bucket of quality. Meet government regulations, provide benchmark for future research, improved customer focus and satisfaction, enhance shareholder and stakeholder value, elimination of defects and waste, improved employee morale, boost medical tourism, tool for continuous improvements at all levels. These are the benefits of incorporating quality in our daily practices. Whatever business it is, healthcare, I think it is a must. So that is what I want to conclude. This is my last slide. So total quality management is the need of the hour for healthcare system in general and specifically for the private and public sector. I conclude this at 4 different levels. 1, to provide a benchmark of quality over the entire organization as a canopy across all levels. 2, to make accreditations mandatory for different levels of organizations. 3, to eradicate practices from most basic unit to tertiary care units that warrant misuse of any product or service that is compromised in patient safety and quality. 4th, to additionally and perhaps most importantly, adopting multiple accreditations which allow the healthcare organizations to proactively address process breakdowns before they become wealth degenerations, reputational setbacks, and life-threatening errors. That concludes my presentation. However, I would like to share one more very brief, just for 2 minutes, I would like to share the screen of my book, which I have authored. But before that, I would like to have a brief discussion with my team members here. Please go ahead.
So you can have the display on the screen and we can start with the interactive session. I feel that will be better. Like display can be there on the screen and certain questions I have, and if others wish to put their questions.
I would love to have questions being asked, even if they don't want to. I am please encouraging. Yes, Nadine.
Swallowing Dr. Afaq.
Walaikum assalam.
Beautiful talk, yeah. Very informative. Jazakallah khair.
Walaikum khair.
Yeah, I have a small question which I fail to understand. How does
Yes.
quality, how does quality, how does ethics, and how does your monetary charging go hand in hand? How those three dots meet each other? Can you just shed some light on that, please?
Quality, ethics,
And charging, the monetary
I'm
charge is
sorry,
what
it
we
was not
charge.
audible.
Yeah, am I
It
audible
is just
now?
two.
I'll repeat again. How does quality, how does ethics, and how is the practice management in terms of charging to the patients go hand in hand? If I could just give you an example, for example.
Yes.
Sorry, I'm going to give an example. I'm just taking a little bit of time. There are two clinics, one clinic in the suburban area, one clinic in the posh area. So one person charges a simple crown of 1,000 rupees with an alginate impression and says, I am doing good ethical practice by charging less material, and I'm delivering the same crown. What is happening in a posh area where they are charging 3,000 rupees using a silicone material and other whatever things to be done in their clinic? So how does ethics come here? So is he following an unethical practice by using substandard quality material and delivering the same crown what the other person is delivering in the posh area?
Absolutely. I mean, there is no second thoughts about it. What I'm basically trying to convey to you, first of all, thank you, Nadeem, for encouraging me. Small encouragement, big encouragement really keeps motivating me, and I'm usually a people's man, and I would love to have constant interactions with you post this session also. So you're free to take down my number. I'll give it in the end. Now, ethics, monetary gains, and what is that?
The quality.
Quality, yeah, sorry. See, when let me also give you an example. When we are having a universal system, the posh clinic and the clinic which is located in a not so posh area, when they're following a universal policy. See, I mentioned that the universal quality should be encompassed like a canopy over the entire organization. So once the quality is being encompassed over the entire organization, this patient will visit that unit and get aware of it sooner or later and come back to a place where there is quality. Do you agree with me on this?
Exactly. But don't you think we are still in the stage of infancy to get the entire...
Absolutely, I agree. I think we are not even infancy. I think we are still in the womb, to be very honest.
Right, correct.
We are taking baby steps, but I would love to, team up with you guys and try to bring about regulations. I was even thinking of, putting forward this request to the health ministry, central health ministry, to come forward and, break down the quacks, because, we are losing lives. During this COVID time, I was one of the task member for the BBMP, and I also launched something called crisis management with a dear friend of mine. I launched Crisis Management of India, a group where we started with 1 oxygen cylinder and we reached up to 1,400 oxygen cylinders. And believe me, these 2 years have been so saddening to see so many cases being, the patients could have been easily saved, just a little bit of quality management. Recently, I saw a prescription, because I sit in a central hub where I get prescriptions from all corners. Baby aged 8 years has been, given 2 antibiotics and 1 steroid for a simple viral infection. Now, if that is documented and a quality system is being documented, now the government taking call may take time. Let us take a call ourselves. Let us have a universal costing system. Universal salary system. 2 years. This should be the minimum pay package. Why should we be the neglected ones? Why should we be the compromised ones? I'm talking about people who are doing extremely well, and I'm talking about people who are not doing well at all. Why should there be any unequivocal distribution of patients? So I agree with you totally. eventually the quality wins. I may go there for a moment and get carried away with the posh setup and everything, but then the crown is going to go away. So I'll come back to the person who is given me quality. So if, again, at the end game, there will be growth financially, reputation wise, and respect wise where there is quality.
I think
Afzal, if you can give me one more question, if you allow me, I'll go ahead. Otherwise, you can take the other questions.
yeah, sure. You can go ahead.
Dr. Afaq, this is my last question. You're talking about universal costing, but don't you think the word universal costing itself is overrated throughout the world? I don't think any of the hospitals, even let it be the best of the best hospitals, they follow universal costing. It's going to basically depend upon your doctor's experience, as you said, the quality of the hospital or the quality of the clinic where the patient is going. So how does universal costing come into play here?
Actually, I worked it out. What you're saying is right. Not right. It is explicitly correct. So I worked out on a particular pattern called as leveling. We have experience of a doctor. So we have level 3 doctor working with 5 years of experience, and he has the liberty to charge a little more than what a level 1 doctor is charging. Now, why does this happen? Why should this happen like this? Is because, again, the experience and various factors come into consideration. So one way to deal with it is leveling, and second way to deal with it is unless and until there is universal costing happening, let's compare us to the world. We are the cheapest dentists in the world. Do you all agree with me? A dental treatment anywhere is costly, but not in India. Still, there are thousands and thousands of dentists who are suffering with practically no income. If you could really excuse me on sharing this note, but I feel this is a true fact. A couple of them have deviated from the main course of thing because they have tried to explore different avenues to earn. Now, when there is a universal costing, we have certain satisfaction telling that the setback of universal costing is there is universal costing for restoration, say 800 rupees, but that gentleman is taking 800, this gentleman is taking 800, then the quality is getting compromised. It won't work. So we need to work with the quality and universal costing together in a forum or on a platform, starting with an individual and reaching out to thousands of practitioners. This is my hearty wish. This is my vision. Because my basic graduation is that, though I'm not a practicing dentist, but because of that factor, I always feel that there has to be universal costing. When you go towards Stani Road side or Shivaji Nagar side in Bangalore, I'm talking about, you will see huge difference. And eventually we see that the best practice is happening, or the best business growth is happening in a place, neither of them. Temporary adjustments are happening in places like this. So universal costing will bring about a huge benefit for the society in large.
Yeah, I think Dr. Nadim is satisfied with the answer.
No, I think he's very inquisitive. He'll have more. So I'll take it later on from him.
Yeah, even I had the same question from someone else, but I have some 3 questions which I'll try to encompass in one question. Can you throw some light on, because all type of practitioners and from all over the globe we are here. So can you throw some light for, especially for the practitioners in India, regarding, in brief, regarding accreditations, how they could get it, like ISO or any other standardizations, and insurance? Because even I have a doubt, because whatever schemes the government, even government empanelments, whatever schemes are been there, we have the dental treatment at the corner somewhere there, and the costs are also not satisfactory, whatever government pays or government norms lay down. So can you throw some light on regarding insurance, accreditations, and government empanelment, like in one, this one, if it could be?
Yeah, please. I don't want to sound business oriented here, but then my organization does take care of accrediting healthcare centers. Okay, medical, we have never done dental so far, but we have done it for hospitals and healthcare units. Okay, so later on, if you want for guidance purpose to approach us, then definitely we will guide you through. As I told you, I don't want to get business. I'm purely here because Dr. Gausia is a very old associate of mine and very dear to me from almost 1.5 decades. So I don't want to sound business now. Coming to the empanelment for government-related schemes, accreditation will help you. Second, accreditation process is very simple. You need to approach the right concerned bodies, meet the right requirements in your organization or in your unit, and then you're empaneled. Third, for insurance aspect of it, insurance companies are now bound or have made it mandatory to only take accredited units gradually. Earlier, it was not the case. Earlier, any organization, whether accredited or not, could have got an association with insurance agents. Now, it is not the scenario. Like Max, United, and all that are accrediting only, are empaneling only the accredited bodies. So they are conscious and they are being directed by the QCI, that is the Quality Council of India, to go forward with only those hospitals and healthcare systems which are accredited. Now, if you're talking about government schemes and government, I don't have much knowledge on it, to be very honest. I don't know how the payment pattern works. I've always primarily been in the private sector. I hope that answers your question.
Yeah. There's one more question. It is like, what is your opinion on present situation of dentists in India? Is there a situation of oversupply and under demand? How do you see future of young dentists?
That is a beautiful question, Dr. Fayaz. See, dear, see, I'm with all humility, I'm telling this. A couple of places Allah subhanahu wa ta'ala sends me as a chief guest or a guest speaker in corporate bodies, Dell, Siemens, Mindtree, all this have been my clients for a long time now. So I give lifestyle coach, motivational talks and all that. Though I'm not good at it, but I still try. I will tell you something. The degree of common sense is a beautiful degree and the best degree one can have. Better than the degree of dentistry or medicine or engineering, the degree of common sense. Why I'm saying this is the future of dentists depends upon how they want to take it forward. This is a reality. But I can tell you a secret, which I have seen in 2 decades of my practice and being in healthcare industry. Any educational qualification is like a weapon, dear. The way you use it is going to make you a winner. You have a weapon and you're not using it in the right manner, then you're going to lose. That's all education is all about. But knowledge is bigger than education. Believe me.
Yeah.
Go for knowledge. Then your education will become sone pe suhaga. The future of any dentist anywhere in the world will depend individually on him alone only. This is my conclusion. Because you see today BDS people are earning in lakhs. And you see an MDS person with a prime located clinic with a prime marketing is not earning. But along with that, another small secret is that you need to have communication skills. As a practitioner, you need to have this. Then is when your future is going to be bright. Your question's answer this is, I don't know what you're doing, but it is in your hands. It is in your individual hands. The future of the dentist in our country is in an individual hands. If you feel that there is excess supply, then we need to diversify ourselves, adapt different methodologies to earn. And once you have quality parameters in your clinic placed, I'm sure gradually Allah subhanahu wa ta'ala will give you growth. Any other questions?
Yeah, anybody from the participants? If anybody has a question.
Impar for a little info on Impar. Impar, Gausia is basically Indian Muslims for Policy and Reforms, which was initiated. We have a team of the top IAS officers and top of the line to engineers and all other people in the country. We basically are working on various policy and reforms in which, the Muslim in general should be saved from being targeted. Okay, we have a team of advocates, we have a team of civil defense line people, the police people. Basically, we are trying to bring about reforms in various places across the country where, people can't just stamp us and go. That was the idea in which it was launched. And we are doing fairly good. Sometimes like recently, in the Independence Day, we made it very loud and clear and exhibited various Muslim fighters, and we ensured that the message was passed across to various national and international media. Trying to revive. That's all I can say. One more question. Thank you. I'm very humbled, and to be very honest with you, this is not my very good presentation because I'm having bad sinusitis and terrible headache. So still, the more interaction happens, the more I present, the more I talk. Anybody who knows me is here?
Assalamu alaikum, Afaq. This is Dr. Iftikhar here. Endodontist, remember. Iftikhar Ahmed. Endodontist, I even consulted your health tree long back.
Oh, very nice, very nice.
Yeah.
Walaikum assalam.
Alhamdulillah, very nice presentation. There's been a lot of gap, and Alhamdulillah, you've grown also from what I saw you. I met you that time and now.
I'm continuing to do further things because as Afzal told, no, change is a wonderful thing, and I keep changing all the time.
Yeah.
You see me after 2 years, you'll probably see me change, probably with a beard also.
Alhamdulillah, inshallah, looking forward to that. My question now is for my actually colleague Afzal, who is from Al-Amin. So I know he also is quite ambitious and.
I can't hear you. Your voice is not audible.
Can you hear me, Afzal? Afzal, please unmute yourself. Afzal.
Yeah. I can. Yeah.
Am I clear?
Yeah.
No, your voice is very low.
Is it? Are you able to hear, Afzal?
हाँ sir, थोड़ा volume बढ़ाना sir.
अच्छा. I don't know. Anyway, I just wanted to know for the. I saw your profile in that it was MBA.
Yes, sir. It's to me.
Yeah. This question is for you.
Yeah.
Okay. So MBA in health and hospital law.
Yeah.
So could you just throw some light on this hospital law? How is it, different from the regular general law? What prospects does that have, especially for dentists? For our participants.
Not very much, sir. I'll brief you. I think later because even time is not permitting. I'll brief you because as far as dentistry is concerned, there is not very much which I have studied, but there is a law management where there is a total chapter. I think if Dr. Afaq Ahmed can throw some light, there is a complete chapter regarding laws related to hospitals and treatments, all the legal aspects.
Okay.
This is basically an administration approach to handle all the legalities in the frame of the Indian Constitution and per se the medical legal cases that happen in our country. So it encompasses all that. So medical record management in itself is a specialty today. MRD, which we call, is a specialty today. Unlike before, it was just part of the subject. Now it is a full-fledged specialty. So we have, for instance, any hospital looking for an MRD specialist or MRD manager.
Okay, fine.
Okay, sir. Jazakallah. Sir, I think it's too much of time also, but still there is one question. If we could conclude before concluding or before the thing, I would definitely appreciate. It was a brilliant session, Dr. Afaq Ahmed Khan sir. Because I know the depth of administration and such things. It is so much, as I mentioned, it's too vast, and it was excellently briefed and to the point. Things were covered. So from the audience, I have one question regarding, because I think even we have, before that, I go to a thing that as you pointed out towards business, once Dr. Ravindra, the IMA president, state president, he was speaking, he said that we are not taught business. Actually, we should have been, because health industry itself is a business.
Very
because
true.
Because they count it as a health industry. So it is definitely for the human beneficial aspect, but it is for the earning of, even we are humans. So that is one thing regarding business. And the other thing is regarding consent forms, pre-printed consent forms. It was somewhere declared, or I think it was a verdict of, I don't exactly remember, it was a verdict of a court or something, that pre-printed consent form should not be entertained. Can you throw some light? Pre-printed. We have a consent pre-printed, and the patient just signs blindly. We say
no, as per the QCI and as per the NABH and my recall memory, you need to have a consent form for all procedures. In case of minor, you need to take it from the attending major, but printed and pre-printed, I'm not sure about this verdict. My knowledge goes, it has to be in form of 2 copies, one the soft copy and second the hard copy. And I just want to inform all of you one more thing, because this question has come up. All electronic data or data is now used as evidence in the court of law. Please keep this in mind. Earlier it was not, but now it is being used as evidence. So when you have a soft copy consent form or a hard copy consent form, I really am not sure about this verdict, but I think it is mandatory to have it. Unless and until, why pre-printed should not be used? How does the court look at it?
No, that was regarding pre-printed, because whatever we know, we print it and the patient blindly signs over that. So in that thing, when the complete total paragraph said that it should not be pre-printed, it should be mentioned and it should be written. And
no. The law says that when you are clicking on, on an app that you agree to the terms and policies, the law presumes that you have gone through it. You cannot, supposing you have booked a hotel and the hotel policy says that you have to check out at 12 and you have not read that and you're blindly saying, they can take you to law for it. I don't think this is a concern, but because I don't know about the verdict, I can't say. But as per my recall memory,
even I don't remember, but it was a strong thing. Verdict is my term, as per, because I was just scrolling through and
as of today, there was a plastic surgery that I had referred to Fortis. They had come with the pre-printed consent form and showed it to me. I saw the case of gynecomastia. I saw all the norms and I told them to go ahead and sign. I don't think it is like that.
Okay, sir. Anyone from the panel?
I think I have a small query. It's not exactly a doubt. See, I think when it comes to consent forms or taking consent from the patient, there's a lot of ambiguity in this region. I mean, the mere fact that the patient is walking in and then sitting on the chair, that itself is a sort of a consent for a treatment. Yeah. But then again, I would not agree with you when you said, I'm talking about Dr. Afzal. When he said the patient blindly signs on it, I think we should be very careful while using our words when we say patient blindly signs on it. I mean, when we are talking about consent form, the purpose of a consent form is to keep the patient informed. That's the reason why it's called informed.
Yes, sir. I do agree with that, sir. But this was the thing printed in some print media or somewhere. I have read it because as far as India is concerned, there were some supporting things which were mentioned, like the language in which it has been printed, and they just mentioned that the treatment has been narrated to me in the language which I understand. So regarding that, there was an issue.
If it is not pre-printed, I mean, what other options do we have in terms of taking consent? I mean, are you just relying upon a verbal consent? Like I said, the patient walking in and sitting in a dental chair itself is a sort of consent.
Yeah, definitely. But this was regarding the legal point of view, as Dr. Afaq says that it is acceptable if even if my term was wrong, blindly signed was mentioned in the article. So even if it is wrong, as Dr. Afaq says, yeah, it is acceptable because, and as you say, yeah, even we defended with the same thing that when the patient comes to me,
documentation here is very important, because see, tomorrow he may come and say that you didn't inform me about it. You know, he should be aware about the risks. Even though you sit down and counsel him and tell him everything, you know, people are very opportunistic today. They get the work done, you know, otherwise they say the grapes are sour. So it's always better that you document.
Assalamu alaikum.
Wa alaikum assalam.
I'm Dr. Basha. Actually, I was just listening to Dr. Nair. Actually, what he's telling is correct. The patient comes, sits down, and he's agreed for the treatment. But as per the law of the country or law wherever I practice, like the Sibahi or the JCIs, they require us to have a physical form, which is like a consent form, which we as doctors explain in detail. We explain in detail what are the complications, what are the treatment options and everything. And that is signed by the patient, or in case if the patient is not there, not able to sign, the guardian will sign. Or if it's a highly emergency procedure or something which is life-saving, we don't even wait for the consent. We take the consent from the consultants, and we go ahead with the surgery. So this is, but it has to be documented and it has to be kept in the file of the patient.
Absolutely.
And this is a very legal document for everything that in future that can come back to you. This is the one that will protect you.
Absolutely. There's no doubt about it. This is the only weapon you have to protect yourself against various aspects of medical legal cases. Okay, even mudslinging, that should not happen in future. From the competitor's point of view also. I also would like to remind all of you to ensure that you enroll yourself for professional tax, if not enrolled, and pay it on a regular time basis, because that is also a very big shield towards such cases.
Well, one more question, Dr. Ashfaq. I just wanted to ask you, is quality expensive?
Quality?
Expensive.
Is quality expensive?
Absolutely not. No, it is not expensive. It is expensive.
Sir, I think it's a to the point answer, and it is quite satisfactory. I feel, because really, Dr. Ashfaq, it was a great session with you, and I didn't even realize how time went off.
I am actually apologetic. There was one question from my dear Gausia that you people can approach me for ISO certification, NABH, or any other certifications. You are most welcome to approach me. Second thing is that I have really not done much justice, because I told you I wanted to show you the book that I have offered and various other statistical figures, but because we have time constraints, probably we'll take it to the next time at the next level. And please feel free to get in touch with me. Dr. Afzal, can you share my number if you don't mind?
Number, sir.
It is 98452.
Yeah.
6338.
We will put it across in the group, Dr. Afaq.
Yeah. I think it's there in the...
that icon for chat has vanished. I've been seeing that. I don't know where it. I got it.
Yeah, I think just before we conclude, I think addendum to what Dr. Salman said, we also with the written and documented consent form, we also have a time in and time out form, just as we do in the OT. In our regular walk-in clinics, we have a form called a walk-in and walk-out, time in and time out. This actually documents as to, this is the responsibility of any the assistant, the dental assistant or the junior doctor, who documents whether the procedure was correct, whether the site was correct, whether what anesthesia was used, how much of it was used, and then this is finally corroborated by the operating surgeon just before the patient walks out.
Absolutely correct.
This is a very important aspect in terms of medical legal aspects. We followed very on a regular day-to-day basis here.
Yes, sir. Even for the general practitioners, patients, like even for simple extractions and all, they claim that the bleeding was not controlled on the chair itself, which occurs even after 1 hour or so. This is a very good point, sir, because when they walk out and they spit out and they do something, even for simple procedures, I think it's a very good point for simple general practitioners.
Again, all these things can be really avoided when you have display system which is mentioning all these points, that you are consent, we are doing this procedure and these are the outcomes of these sort of procedures if it is being displayed. And I've been encouraging most of our members to have a digital display wherein you can express your services, your costing, digital display in form of a system, monitoring kept in. Patients can know that this service is also being done and this is my right, and everything all roped into one particular place. I think that should help.
Okay, sir. Jazakallah khair.
Welcome, khair. Thank you, everybody.
Many thanks.
Thank you, everybody, for bearing with me patiently and listening to me.
Thank you all. Thank you, one and all. Thank you, sir, once again for a brilliant session.
It was my pleasure. Thank you, everyone. I'm logging out. Take care.
Thank you, Dr. Afzal. That was a really good and very informative session. Thank you, Dr. Afaq. I think we will end